Lactate, lactic acid, lactic acidosis. These are very topical terms that are used in the literature. They're used every day on ward rounds. I'm going to explain how we generate lactate in our body, what happens with it, and why patients develop lactic acidosis. The sour taste of milk. This is a tutorial about lactic acidosis. Welcome back. In the previous tutorial, we discussed electrical neutrality, and we discussed the Boston School and its contribution to metabolic acidosis, and then how the Copenhagen School developed the base excess and the base deficit as a way of refining our understanding of how we can diagnose metabolic acidosis. I then discussed the anion gap and its strengths and weaknesses, and how this is a universal tool that's used by clinicians everywhere, but is based on electrical neutrality. I discussed how you can adjust the anion gap for modern practice by changing the albumin effect and looking at lactate and indeed ketones. Then we looked at alternatives of the anion gap, the strong ion gap, the base deficit gap, and ways of actually getting all of the information about acid base using a variety of different calculations that are folded into specific smartphone apps that do all of the work for you. This tutorial is on lactate and lactic acidosis, and I'm going to start with the biology of lactate, how it accumulates in the body, and what lactic acidosis is and what it is not, and how you should think about treating it and how you should not treat it. One point I'm going to make at the outset is that hyperlactatemia and metabolic acidosis, or lactic acidosis, is a powerful biomarker of acute critical illness. However, there is an awful tendency to look at lactate as being a bogeyman substance that you measure in clinical medicine, and that somehow or other this particular molecule is evil and nasty and it does all kinds of horrible things to the body. What I'm going to try and convince you about in this tutorial is that lactate is an absolutely essential metabolic fuel that is used all over the body for all kinds of reasons, and that it accumulates in certain diseases associated with critical illness, and therefore is a marker of critical illness, but not a product that damages organs. So what we should understand from the outset is hyperlactatemia and metabolic acidosis is a poor prognostic sign in critical illness. And you can see by, for example, this particular study where they showed looking at different types of metabolic acidosis that the mortality rate associated with lactic acidosis is very high. But I will principally try and explain that that is caused by diseases that drive up the lactate levels rather than the lactate itself causing the disease. And the higher the lactate level, the slower the clearance of lactate, the worse the patient outcomes. Now I'm going to start with 4 clinical scenarios with which to illustrate lactic acidosis. Jack is a 24-year-old motorcyclist who has been hit by a car and brought to the hospital. He has multiple long bone fractures. There is a fractured pelvis. He has lung contusions. On examination, he is cold and clammy. His heart rate is 120 and his blood pressure is 100/60. On blood gas analysis, his pH is 7.01. His plasma lactate is 15 millimoles per liter, and his hemoglobin is 7 grams per deciliter. The second case is Brian, who's 27, who has a history of severe asthma. He was admitted at 2 p.m. to the emergency room with severe shortness of breath. He was given corticosteroids, antibiotics, and continuous nebulizers. That nebulizer contained albuterol or salbutamol, and that went on for 2 hours. At 4:14 p.m., his heart rate is 120 beats per minute, his blood pressure is 110/70, and he's a little bit confused. A blood gas is performed, his pH is 7.15, and his plasma lactate is 9 millimoles per liter. Alicia is 19, and she has been admitted complaining of abdominal pain. She is intermittently confused, and her heart rate is 120 beats per minute. Her blood pressure is 95/50. On a venous blood gas, her pH is 7.1 and plasma lactate concentration is 8 millimoles per liter. Finally, Melissa is 59. She has a history of diverticulitis and type 2 diabetes. She presents to the emergency room with grumbling abdominal pain and malaise. She looks reasonably well and the physical exam finds nothing. Her venous lactate is 12 millimoles per litre. Now I will return to each one of these cases later on, but keep them in the back of your mind. Let's start with a discussion about the biochemistry of lactate. Most doctors break out in welts when the word biochemistry is mentioned in their presence, but it's really important that, regardless of your clinical background, you understand the absolute basics here. At this point, I want to make a personal disclosure before I go any further, because I have really struggled with this topic for decades. When I was a student in school and in college, I was taught that the endpoint of simple glucose metabolism was pyruvate, and that in anaerobic conditions, when there was inadequate oxygen present in the system, pyruvate was fermented to lactate, which was really inefficient from an energy perspective. Nobody seemed to discuss what happened to the lactate subsequently. In the late 1990s, lactate measurement became part of the standard blood gas, and at that stage I was taught that high lactate was indicative of global oxygenation failure, secondary to shock, and that patients needed a robust fluid resuscitation to deal with this. This morphed into the belief that lactate could be cleared from the circulation in some way with fluid. Simultaneously, I was taught that I should not give lactated Ringer's solution or Hartmann solution to diabetic patients because they can't handle lactate. Now, I have gleefully ignored the latter instruction for decades and have yet to encounter a patient who had sodium lactate-induced metabolic meltdown. But regardless, if your knowledge and understanding of lactate is based on the belief that it is a rare commodity in the body and that its measurable presence always means cardiovascular collapse, then I expect to shatter those beliefs in the next few minutes. To understand lactate metabolism, you must start with carbohydrates. And carbohydrates are ingested into the mouth, and that's where metabolism starts, right there in the mouth with saliva, and then it gathers pace in the stomach. The goal of this process is to convert various moieties of carbohydrate into glucose, which is the universal substrate for the body. This is what glucose looks like. It's one of the few chemical formulae that everybody seems to know, C6H12O6. It has a molecular mass of 180 grams per mole. And in this tutorial, I'm going to use this grey ball with a G on it to represent glucose. Now I want you to hold your breath for a second because I'm about to show you some chemical formulae. There are three chemicals that I have presented in this picture, starting on the left with glucose that has a chemical formula of C6H12O6. One molecule of glucose is broken down to two molecules of pyruvic acid, that is C3H4O3, which of course drops a hydrogen ion to become C3H3O3 pyruvate. This is further reduced to lactate by lactate dehydrogenase. Lactic acid has a chemical formula of C3H6O3, which is half a glucose molecule, and of course it also drops a hydrogen ion. And so this is what lactic acid looks like, and the hydrogen ion drops off that and it attaches to a blob of water. The pKa of pyruvic acid is 2.45 and the pKa of lactic acid is 3.8. So there is only pyruvate and lactate intracellularly and extracellularly across the entire range of physiologic pH. Once glucose is in the bloodstream, it becomes available for utilization by cells. Glucose enters the cytosol of the cell where it enters the glycolytic pathway, at the end of which two molecules of pyruvate are manufactured. In this example, one molecule enters the mitochondrion and the Cori cycle, and this results in highly efficient production of carbon dioxide and energy. The other pyruvate molecule is fermented or reduced into lactate by lactate dehydrogenase. It is then expelled from the cell via a transport protein. Once outside the cell, the negative charge induces a change in water configuration to express hydrogen ions, and this causes a fall in the pH. Some of that lactate enters different cells and is converted back to pyruvate, which is rapidly oxidized and enters the mitochondrion to undergo oxidative phosphorylation. In this way, lactate is a partially metabolized rapid fuel rather than some useless waste product. Lactate can also undergo reprocessing back to glucose in the cell, a process known as gluconeogenesis, providing substrate that can be used for energy, to refill glycogen stores, and to make fat. I want to take you through some numbers and you will find these startling. I will point out that these are conservative estimates and the numbers may be significantly higher. We ingest about 300 grams of glucose per day that we use directly for energy. The molar mass of this is 300 divided by 180, and that equals 1,665 millimoles per day. That glucose is broken down into 2 molecules of pyruvate that enter the Krebs cycle and generate ATP and carbon dioxide. Now, some of that pyruvate is converted to lactate by fermentation. The real proportion of glucose that ultimately ends up as lactate is much higher than you could possibly imagine if you just know high school biochemistry. That percentage is 35% and it may be higher. That works out at about 115 grams. And if you divide 115 grams by 90.8 grams per mole, that's the molar mass of lactate, that works out at 1,250 millimoles of lactate that are produced each day with normal activity. That is a staggering amount. In comparison, there are about 2,100 millimoles of sodium in the extracellular fluid, only a small proportion of which is turned over per day, between 50 and 80 millimoles, about 1.5 grams. Let's look at the sources of lactate that compose that 115 grams per day. About 25% of resting lactate production comes from red blood cells or erythrocytes. These have no mitochondria. Red cells cannot afford the space for additional organelles as they have to carry around a big chunk of hemoglobin and then squeeze into the smallest capillaries. It is ironic that the cells that carry most of the oxygen in the body cannot use it. The other organs that produce a lot of lactate at rest include the skin, the brain, skeletal muscle, the kidney, and the bowel. Obviously, the skeletal muscle output can ramp up exponentially with exercise. If you happen to encounter any of those folks who believe that you shouldn't give Hartmann solution or lactated ringers to patients with diabetes, it may be worth pointing out that the red cell production alone of lactate is equivalent to the lactate content of 11.5 liters of sodium lactate solution. I want to introduce you to a concept that you may be unfamiliar with, the lactate shuttle hypothesis. This is based on the fact that lactate is produced by one tissue that either can't use it or doesn't want to use it, and it is then shipped to another tissue that may be very energy hungry and finds this partially metabolized substance very appealing. It's a bit like those energy gels that cyclists use, or hamburgers. They're equivalent to a steak that somebody has already chewed, and it makes it much more easy for you to digest once you start eating it. The essentials of this concept are that there are tissues that continuously make lactate and export it. Perhaps like the red cells, they're unable to oxidize pyruvate. Perhaps the tissues are in a good position to prioritize the production of lactate and preserve glucose and glycogen. But regardless, other tissues may be very energy hungry, and crucially, lactate is partially metabolized already. It is half a glucose molecule and almost instantaneously available to be fed into the engine room for energy production. That is the Krebs cycle. The organs that most utilize lactate are the heart and the brain. They love lactate. For them, it's like cotton candy or candy floss. They'll just gobble it up all day long. And a way I sort of look at lactate versus glucose is that glucose is a universal substrate, but lactate is a universal fuel. It can be used by virtually any organ system in the body. Aside from how lactate is utilized by the Krebs cycle, it is also reprocessed back into glucose by a mechanism known as the Cori cycle. About 70% of whole body lactate clearance occurs in the liver. Lactate is transported out of the cell where it causes water configuration change. Hydrogen ions appear, lowering the pH. Conveniently, bicarbonate is around to buffer up those hydrogen ions, generating carbon dioxide. Then the lactate molecules travel to the liver where they undergo gluconeogenesis to make glycogen or aerobic metabolism to generate bicarbonate. Remember that it takes 2 molecules of lactate to regenerate 1 molecule of glucose. Most tissues, including the brain and kidneys, can metabolize lactate and regenerate glucose from it. And again, this is known as the Cori cycle. It's worth looking at the energetics because the Cori cycle is not energy efficient. The production of lactate by hydrolysis in red cells, for example, and skeletal muscle does yield 2 particles of ATP, providing instant energy. But when lactate is transferred to the liver for gluconeogenesis, it costs 6 ATP equivalents to regenerate glucose. That energy is derived from fat oxidation locally in the liver. The way that I suggest you look at lactate is as a continuum of sites that produce the product, that metabolize the product, that utilize the product and regenerate it. So we have, for example, a skeletal muscle and bowel that produce lactate. Skeletal muscle is on the systemic circulation circuit. The bowel is in the splanchnic circulation, as is the liver. And the liver is the principal site of lactate metabolism or clearance. Lactate is consumed by various tissues, principally the heart. In the next few minutes, I'm going to use this cartoon intermittently to demonstrate lactate production, distribution, and clearance. That little factory there represents the liver. Under normal circumstances, the clearance capacity for lactate significantly exceeds production, and as a consequence, the lactate level in plasma is undetectable. For a patient to develop lactic acidosis, the production must exceed the clearance, and that can be a problem of either excess production or inadequate or relatively inadequate clearance, or both. So let's get into lactic acidosis. And the key point I want to make from the offset is that a raised lactate level does not always mean inadequate tissue oxygenation. And the reason for this is because of the stress response and the presence of adrenaline or epinephrine and other catecholamines in the system. Peripheral muscular cells, the vasculature and the heart have all got adrenoceptors alpha and beta. The stress response causes the release of catecholamines that activate these receptors. Adrenaline activates lactate dehydrogenase, the enzyme that makes lactate from pyruvate, and this redirects intracellular pyruvate away from the mitochondria to the formation of lactate. There is a dramatic increase in skeletal muscle blood flow, and lactate production increases, but so too does lactate clearance. Consequently, there is an increase in the plasma lactate level and the plasma glucose level and oxygen delivery to the tissues. Although the production of lactate may exceed hepatic clearance capacity, the liver is still working very well. It's just been a little bit overwhelmed. As the mixed venous oxygen saturation is usually normal in these circumstances, this process is sometimes known as aerobic glycolysis. This is how I look at the relationship between catecholamines and lactate. As the level of adrenaline or epinephrine increases, so does the lactate. The greater the degree of stress, the greater the catecholamines, the higher the lactate. So in stress situations, lactate production increases and clearance is also increased, but production may exceed clearance. So we go from our normal situation with a large lactate clearance capacity versus production to a situation of stress hyperadrenergia where the lactate production increases exponentially and may exceed the capacity of the liver and the kidneys to clear it, so that lactate becomes measurable in plasma, manifest as lactic acidosis. Over time, production gradually falls back to normal levels and the various organs go about clearing the surplus. Once the clearing capacity exceeds the combination of current production and surplus, then the plasma lactate begins to fall. The term for a falling plasma lactate is clearance, and it happens because of metabolism. Now let's move on to hypovolemic shock. In hypovolemic shock, circulating volume is lost and the major compensatory mechanism is hyperadrenergic activity. All those adrenoceptors get bound up, and the major impact of this on the circulation is intense vasoconstriction. The cardiac output usually falls. So there is increased glycolytic activity from a combination of catecholamines and low flow, that is anaerobic glycolysis. There is low flow to the gut, so there's more glycolysis there, and there's low flow to the liver, which reduces the capacity of the liver to clear lactate. All of this results in lactic acidosis, hyperglycemia, and low mixed venous oxygen tension. There is global hypoperfusion. There is a fall in cardiac output. Because venous return has reduced, there is lower left ventricular end diastolic volume and an increase in the ejection fraction. There is a low stroke volume and increased stroke volume variability with the respiratory cycle. So in hypovolemic shock, lactate production increases and clearance is reduced. So we go from this situation to this situation. As a consequence of hypovolemic shock, the tissues are screaming from oxygen debt and lactate production increases exponentially. Simultaneously, the hepatic clearing capacity falls due to reduced splanchnic blood flow. The result is high plasma lactate and lactic acidosis. Sometimes this is called type A lactic acidosis. This is resolved with resuscitation with appropriate fluids such as blood products and the reduction in the adrenergic stress response with increased oxygen delivery to the tissues, and that results in a fall in the lactate production with improved clearance. And as a consequence, that lactate level begins to gradually reduce as the liver is clearing the lactate that's already there and the lactate that has been currently produced by the tissues. In the situation of a large trauma or major blood loss, lactate should clear at a rate of somewhere between 10% and 20% per hour. You want to see that number going downwards, not going upwards. If lactate fails to clear in hypovolemic shock, you must consider an alternative problem or a synchronous problem going on. For example, there may be an ischemic bowel present due to low flow. Sometimes in chronic liver disease or late-stage sepsis, there is normal lactate production by the tissues, but the liver or the kidneys or both are unable to clear lactate normally. The clearance capacity is reduced such that there are low levels of lactate detectable in the blood. In sepsis, the cause is unknown. Regardless, what you may encounter is a high plasma lactate with a normal pH, with a normal bicarbonate and a normal base excess. The body has had a chance to compensate for the excess presence of this strong anion and has compensated by wasting chloride in the urine. And as a consequence of this, the strong ion difference increases. There are toxic causes of lactic acidosis, the most well known of which results from a toxic effect from fenformin and metformin. Metformin is the drug that you're going to encounter in clinical practice. It's an oral hypoglycemic agent. And once the drug is administered, it appears to damage the liver, impairing hepatic clearance and resulting in a temporary lactic acidosis. That acidosis resolves relatively quickly. The patient appears remarkably well, despite often really scary levels of hyperlactatemia. The traditional approach to assessing lactic acidosis is to divide it up into two types. Type A, which is hypoperfusion, and hypovolemic shock. There is an oxygen debt and you have high lactate, high glucose, low mixed venous oxygen saturation, and a reduction in the stroke volume and the stroke volume variability. Type B is lactic acidosis caused by pretty much everything else. So when you see a patient with a lactic acidosis, I think this is a good way of working the problem. First question is, was the patient involved in a trauma or are they obviously bleeding? You can check the hemoglobin and the mixed venous oxygen saturation, control the source and resuscitate preferably with blood products. If not trauma or bleeding, is this sepsis? Look for a source, look for markers of sepsis, look like CRP, a procalcitonin that's raised, a high white cell count, evidence of infiltrates on the chest x-ray, confusion, etc. Give antibiotics, resuscitate with a moderate dose of crystalloid and control the source. If not sepsis, consider liver dysfunction, a toxic cause, and in particular, bowel ischemia. Now, let's revisit the 4 clinical scenarios that I mentioned at the beginning of this tutorial. The first was Jack, a 24-year-old motorcyclist that was hit by a car. He had multiple long bone fractures, has hyperadrenergic, has a lactic acidosis, and is anemic. This is classic type A lactic acidosis. Jack needs surgical source control, including a pelvic binder, high-quality vascular access, and resuscitation, preferably with blood products. The lactate level indicates the level of stress, but it should not be used as an endpoint of resuscitation. You need to follow it and see if it's clearing, but don't just keep giving fluid to the patient because the lactate remains high. The liver needs time to process the lactate. You cannot force the liver to clear lactate with fluid, and eventually if you give enough fluid, the flow across the splanchnic circulation becomes sluggish because the venous side of the circulation becomes hypertensive. The causes of type A lactic acidosis are all the situations where production of lactate exceeds clearance. We see this with extreme exercise, we see it with seizures and hypovolemic shock and cardiogenic shock, and in toxic situations where, for example, the hemoglobin cannot deliver oxygen to the tissues, such as in carbon monoxide poisoning or different hemoglobinopathies, and of course with cyanide poisoning, which poisons the mitochondrial chain. Brian, as you recall, is a 27-year-old asthmatic who came into the ED and then got continuous nebulizers for a couple of hours. And when he got a little bit confused, somebody did a blood gas and found that he had a rip-roaring lactic acidosis. A lot of mistakes could be made at this stage. Because of the surviving sepsis guidelines that emphasizes confusion, tachycardia, and a high lactate, and then insists on you giving the patient fluid, this patient could go down a completely wrong pathway that may well hurt him. But in fact, Brian's lactic acidosis is being driven entirely by catecholamine therapy. It is a clinical artifact. It does not indicate a pathology or prognosticate the patient's outcome. You should generally ignore the lactate level and not fluid resuscitate this patient who likely has some diastolic dysfunction from all of the catecholamines. This is aerobic glycolysis. You will also see this in any situation where you start an epinephrine or adrenaline infusion on a patient. For whatever reason you might do so, you will immediately see a rise in the plasma lactate that again is semi-artifactual. Alicia is 19 and she's come in complaining of abdominal pain and she is intermittently confused and her heart rate is 120 beats per minute and her blood pressure is 95/50. On a venous blood gas, her pH is 7.1 and plasma lactate is 8 millimoles per liter. In this situation, Alicia likely has sepsis and this is septic shock, and the treatment is broad spectrum antibiotics. You should consider and probably administer 30 mils per kilo of balanced salt solution with early administration of vasopressor drugs, norepinephrine with or without vasopressin. You need to consider a medical versus a surgical source, and this patient needs source control. A progressive fall in the lactate is reassuring. If it does not clear, the source has not been adequately controlled. Melissa is 59 years old and she has a history of diverticulitis and type 2 diabetes. She presents to the ER with grumbling, abdominal pain and malaise, although she looks reasonably well. Her vital signs are not extraordinarily abnormal. You examine her, there are no specific findings on physical exam, and her venous lactate is 12 millimoles per litre. When you see a patient like this with a very high lactate, in this situation 12 millimoles per litre, who does not look particularly unwell, you can pretty much outrule sepsis and hypovolemia. This is type B lactic acidosis, and there's a way of working this problem. Always start off with toxic, for example, alcohols, ethanol, methanol, ethylene glycol poisoning, etc. You should calculate the plasma osmolarity and measure the plasma osmolality so that you can derive the osmol gap. Certain drugs can cause this: metformin, nitroprusside, acetaminophen, that's paracetamol, and HIV drugs. Consider diabetic ketoacidosis that may manifest with hyperlactatemia, consequence of a lot of adrenergic activity that accompanies ketoacidosis. Liver disease, fatty liver, hepatic steatosis and cirrhosis, neoplasms, lymphoma, leukemia, and vitamin deficiency, particularly thiamine. Melissa was recently prescribed metformin, and although the diagnosis of metformin toxicity is likely, it is a diagnosis of exclusion. This patient needs a full workup, an ABG with co-oximetry. Remember, you need to look for methemoglobin, you need to look for carboxyhemoglobin, etc. A complete blood count with a blood film, electrolytes, thyroid function tests, liver function tests, an abdominal ultrasound, chest x-ray, urinalysis, HIV test, etc. And once everything else has been outruled and you're not going to give her metformin and there really is nothing to do, if it is metformin, then you can say, yeah, this was the metformin that did the damage. But you've got to outrule everything else first. A question that I'm frequently asked at conferences or after giving lectures is, can the lactate in sodium lactate solution, that's Ringer's lactate or Hartmann solution, cause a metabolic acidosis? And the answer is usually not. Sodium lactate solution is a balanced salt solution. It's electrochemically neutral. And as a consequence, that lactate is balanced by sodium principally. It contains 28 millimoles of lactate, 40 millimoles of L-lactate, and 40 millimoles of D-lactate, so it's racemic. And both isomers are easily metabolized in the body. But it's worth pointing out that only one of these is actually produced by the human body, and that is D-lactate. Human lactate dehydrogenase can only make D-lactate, and the ABG machine, the arterial blood gas machine, only measures D-lactate. L-lactate can be manufactured or fermented by gut bacteria, and then that lactate may be absorbed into the body. The quantities are usually too low to overwhelm hepatic clearance and result in a lactic acidosis. However, occasionally we see a patient with severe bacterial overgrowth of blind loops and they have a lactic acidosis that's driving a drop in the pH. That lactate, L-lactate, can be measured by the lab. Now in this tutorial, I have only scratched the surface of lactate biochemistry and metabolism. It is a truly fascinating particle that is involved with energy regulation, immunity, memory formation, wound healing, ischemic tissue injury, cancer growth, the development of metastasis, etc. It has all kinds of effects in signaling and in metabolism in the body. And I would recommend that you read one of the many review articles that have been published in the last decade or so on lactate, rather than the obsession that we have in intensive care and emergency medicine with lactic acidosis. Let's review this tutorial. So this tutorial was about lactic acidosis, but I very heavily emphasized the biochemistry of the molecule lactate, and I looked at glycolysis, both aerobic and anaerobic, and lactate clearance. I pointed out that lactate is not a waste product, it is a fuel. We then moved on to discuss lactic acidosis, and I started with a discussion about stress hyperlactatemia. That is a situation where there is a dramatic increase in circulating catecholamines, driving production of lactate, increasing clearance, but you still get a lactic acidosis. there is an increased cardiac output, and there tends to be a high mixed venous oxygen saturation. We call this aerobic glycolysis. Conversely, in situations of blood loss or trauma, the patients develop a shock state and there is an increase in anaerobic glycolysis. Blood sugar initially remains relatively normal, but a falling blood sugar with a rising lactate is an anomalous situation. The cardiac output tends to be relatively low, with low stroke volume and high stroke volume variability. I then moved on to talk about hyperlactatemia and lactic acidosis in the setting of sepsis and in the setting of organ, particularly liver dysfunction. That is known as type B lactic acidosis, and you need to be extremely careful that you tease out the underlying cause of this and not misdiagnose all lactic acidosis as due to, for example, blood loss or sepsis. Now in the next tutorial we're going to move on and talk about ketoacidosis. I'll start off again with the physiology and biochemistry of ketones, their production and their metabolism, and explain why ketone production may become out of control in diabetes, and this is known as diabetic ketoacidosis. I will then move on to discuss an array of situations where patients become ketoacidotic despite not having the underlying process that causes diabetic ketoacidosis. This is known as euglycemic ketoacidosis. I'll see you then, and I guarantee you'll learn something. So that was lactic acidosis. I hope you found it useful. If you did, please subscribe on YouTube, leave me some comments and some likes, or follow me at ccmtutorials.org. Next time we're going to talk about ketoacidosis.